Good morning. Today we'll be discussing permanent sterilization, that is the final topic among the family planning methods. Last week we had discussed about the barrier contraceptives and natural methods of contraception. Hormonal contraception, I assume, has been discussed again. The other topic left was of intrauterine contraceptive device. These were all the temporary methods. Today we will be dealing with permanent method of sterilization. So at the end of the class, the students should be able to know what is permanent sterilization, what are the indications and contraindications of these methods, and the student should be able to describe the various procedures in brief and then complications of these methods. So permanent sterilization is a terminal method of contraception, and it is a one-time method. Once it is done, it is over. This includes both surgical and non-surgical. Mostly it is surgical and exists for both males and females. These procedures are intended to be permanent. Reversal is generally difficult or impossible. That's why the counseling to the patient is very important. And sterilization offers many advantages over other contraceptive methods. So the types of sterilization, it can be either female sterilization, which is tubectomy, or male sterilization, that is vasectomy. In both these methods, there is a tubes which either carry the sperms or ova. They are separated or obstructed by some of the other methods. Here it will be the fallopian tubes, and in case of male, it will be the vas differentia, which will be dealt with regarding the surgery. So female sterilization, also referred to as tubectomy, it is a surgical procedure in which a woman's fallopian tubes are clamped and blocked or severed and sealed. So either method of which prevents fertilization of oocytes and its transport to the uterus for implantation. Tubal ligation is considered as a major surgery, usually done under spinal anesthesia. And with the traditional ligation, the surgeon severs the tubes and then ties them off, thereby preventing the travel of the eggs to the uterus. So in this method, usually the surgeon will make an incision over the anterior abdominal wall. The site and the size depending on the type of tubectomy to be done, which will be coming to later, in order to gain access to each of the two fallopian tubes. So this is some of the methods, and other methods include using the clips or rings to clamp them shut, or severing and cauterizing them. So in some way or the other, these tubes have to be separated, or there should be obstruction in these tubes. So if this is fallopian tubes, it is tied and cut. This is the cauterized and they are separated. And this is banded with some other material. The details will be coming to later. So what are the advantages of tubectomy? It is a single procedure which leads to lifelong, safe and very effective family planning method. It has got a low failure rate. Usually the first year it is 0.1 to 0.5% and 1.8% in 10 years. That is very low. And there is, once the method is done, as far as the woman is concerned, there is nothing to remember, no additional supplies needed, and no repeated clinic visits required, except during the immediate post-surgical period. There is no interference with the sex, no known long-term side effects or health risks. It is supposed to reduce the pelvic inflammatory disease, and then there is protection against the ovarian cancer. The disadvantages are very less. It can cause infection or abscess of the wound. In some cases, there may be menstrual disturbances, and death is very rare, and usually it is due to the procedure or anesthesia. So guidelines for sterilization in our country. They are provided free of charge in government institutions. and guidelines have been issued from time to time by the government covering various aspects of sterilization. The age of husband should not ordinarily be less than 25 years, nor should it be over 50 years, and as far as the woman is concerned, it should not be less than 20 years or more than 45 years. The motivated couple should preferably have 2 living children at the time of operation, but regarding the recent guidelines, even 1 child is enough, but preferably it should be 2. So if the couple has 3 or more living children, the upper limit of age of husband or wife may be relaxed at the discretion of the operating surgeon. Otherwise, it is 50 for males and 45 for females. So before the operation, consent should be taken for legal purpose. So female sterilization is very popular in India, besides other methods. And it is the most popular method in the country of, we've got now 1.3 billion people. Mass sterilization programs were introduced to limit India's population growth in 1976, that is during the time of emergency. Sometimes unnecessarily sterilizations also were done. So if you take the average use of various contraceptive methods, it is assumed that just over 37% of females aged between 15 and 49 years, that is a reproductive period, who are married or in a sexual relationship, say that sterilization is their method of contraception. So females also prefer sterilization as a contraceptive method. That compares to very low figures of 3.1% who use the pill and 5.2% who said they use a male condom to keep from getting pregnant. So after female sterilization, it is the condom which is popular, though the gap is very high. So India has more women who rely on sterilization to prevent pregnancy than any other country. So India's family planning program usually focuses predominantly on women with little interaction and engagement in men. So it is the women who suffer, who have to bear the children, who bring up the children, and they know their difficulties. But at the same time, it is the men who often decide when to have sex and how many children to produce, and women usually doesn't have any say. Because male sterilization is not socially well accepted in India, this mostly means that we deal with female sterilization. And this persists in India as a method practiced with or without the consent of the women, which is unfortunate. So what are the indications of female sterilization? Mainly it is for family planning purposes, that is if there is a multiparous woman. So after doing 3 cesarean deliveries, then medical disorders which make subsequent pregnancies at high risk. Some psychiatric problems also may be an indication for female sterilization, and breast cancer. Contraindications are not many. As per the government of India, a woman younger than 25 years should not undergo female sterilization. Parity less than 2 children, but now it has been brought down to minimum 1 child. And if there is local infection, then female sterilization should not be done. What is the right time to undergo this operation? When a woman decides that she will never want children in the future, that means that is the finishing of her obstetric career, and it is reasonably certain that she is not pregnant. This is why usually it is not performed during the latter half of the menstrual period. So time of operation, it can be either performed during puerperal period. The operation can be done 24 to 48 hours following delivery, up to 7 days. Interval, the operation is done beyond 3 months following delivery. It can be immediately after abortion, within 48 hours, or any other time, but not between 7 days and 6 weeks postpartum, and preferably should be done during the proliferative phase of the menstrual period. And usually during the puerperium, the woman is quite motivated for tubal sterilization. So that is when we should catch the women for female sterilization. And its chief advantages during period, it's simpler to perform tubectomy, and at that time the woman can have hospital stay and rest at home following delivery. For whatever rest she has to have with further delivery, the same type of amount of rest is required for tubectomy. So both procedures, means both events, that is the delivery and the female sterilization, can be combined, and there is no extra period required for rest for the woman. So she is recovering simultaneously from the two events, that is the delivery and tubectomy. And then it can be done concurrent with MTP, that is performed along with the MTP, then concurrent with cesarean delivery with prior consent of the woman. So what is the basic qualification requirement of the provider of female sterilization? One is the mini lab services. Any trained MBBS doctor can do this surgery. And another is laparoscopic sterilization, for which a minimum qualification of DGO or MD or MS in obstetrics and gynecology or MS in general surgery is required, and who is trained in laparoscopic sterilization. So when a woman can have sterilization? Most women can have sterilization at any time, but may have to wait if she has given birth between 1 and 6 weeks ago, or there is a doubt of being pregnant, if there is an infection or other problem in female organs, or some other serious health condition, then the procedure should wait. What are the case selection criteria? They include clients should be married, females should be above the age of 22 years, preferably 25 years, and below the age of 49 years. The couple should have at least one child whose age is above 1 year, otherwise it is contraindicated. And clients or their spouses, partners, must not have undergone sterilization in the past. However, this is not applicable in cases of failure of previous sterilization. Then clients must be in a sound state of mind so as to understand the full implication of sterilization, which is a permanent method. Mentally ill clients must be certified by a psychiatrist, and a statement should be given by the legal guardian or spouse regarding the soundness of the client's state of mind. So there are certain medical conditions for which the tubectomy should not be done in a peripheral center, though it is otherwise authorized for this surgery. So these cases which have the following medical condition should be referred to tertiary care centers. So the woman, if she is having cardiovascular disease, moderate or severe hypertension, diabetes mellitus of more than 20 years duration with complications, complicated valvular heart disease, hyperthyroidism, chronic lung or liver disease, marked obesity, and pelvic tuberculosis. So if the woman has got these conditions, it is better to refer these patients to a higher center. Counseling is very important in cases of female sterilization. We should explain to the patient that this is a permanent procedure for preventing future pregnancy, and this surgical procedure has a possibility of complications, including failure requiring further management. It does not affect sexual pleasure, ability, or performance. There is no effect on client's strength or ability to perform normal day-to-day activities after a few days of surgery. However, there is no protections against reproductive tract infection, sexually transmitted infections, or HIV and AIDS. Reversal of sterilization is possible, but it involves major surgery, and that its success cannot be guaranteed. So, before a woman decides to undergo surgery, she should discuss with the medical authorities that it is that she should be explained that there are temporary methods are also available, and sterilization is a surgical procedure. It has risks and benefits and prevents having any more children and it's a permanent method. So that's why decision on the part of the woman should be carefully considered, and that she can decide against procedure anytime before surgery. So one should, that's why counseling is quite important before female sterilization. So again, the same explanation. We should also tell that this procedure is very effective, very safe, and womb will not be removed. So she continues to have a menstrual period. There are no long-term side effects. And if our client wants to know more about sterilization, we can explain much more. Again, we have to explain about the procedure of sterilization which is going to be undertaken, and that she will be given pre-medication which will help to keep her calm, and it will act like an analgesic, and that she will remain awake in case spinal anesthesia is given. And the cut made is quite small, which can be small over in the suprapubic region or near the umbilical region. And in this procedure, tubes will be blocked or cut, and opening will be closed with stitches, and she will require a few hours rest if there are no complications during surgery. And after the procedure, she should rest for 2 to 3 days, avoid lifting heavy weights for a week, and she should not have any intercourse for approximately 1 week after the surgery. What are the prerequisites for sterilization? One is the informed consent, which is very important. And the consent should not be obtained under coercion or when patient is under sedation. She should sign the consent form before sterilization surgery. There are special consent forms for tubectomy which has been issued by the Government of India, in which apart from the procedure, it has been described that there are chances of failure, and patients should be aware about it. And that consent of the spouse is not required. However, to be on the safer side, it is better to take the consent. However, legally it is not required. Then before the surgery, one should do detailed clinical assessment and screening. Basic lab investigations like hemoglobin, random blood sugar, urine routine should be done, and if she is elderly, ECG also can be done. And checklist of various requirements should be signed by a medical officer who will be doing this female sterilization procedure. Pre-operative instruction to the patient is very important, that she should be nil orally for 6 hours prior to surgery, and bowel should be emptied. Bladder should be emptied before entering operation theatre. Remove glasses, contact lenses if she has got, dentures and jewelry. And a responsible adult must be available to accompany the client back home after the surgery, because in many places it's a daycare event. The patient is sent back home on the same day. Then the part preparation with trimming of hairs is required. It's not the shaving. Anesthesia local, spinal or general according to the anesthetist, that is the anesthetist's purview. The surgical procedure carried out as per the standard guidelines. So what are the various methods of sterilization, or I would say the route of this thing, how the tubes are approached? The most common is was laparotomy, which is performed during cesarean section and various other gynecological and other surgeries. Then mini laparotomy, which is common, which is done during interval period or postpartum, and the usual method employed, and as the Government of India instructs, it should be modified polymerase technique. Vaginal ligation also can be done, however it is not being done nowadays. Then laparoscopic tubal ligation has become quite popular during the past few years. And another method of doing sterilization is hysteroscopy, either through the chemical agents or a method called as SHO. So the routes, like I said, it can be abdominal or vaginal. Though the vaginal approach was popular some years back, now it has been abandoned. So there are some disadvantages of both the procedure. So that's why we should know because there are more advantages of an abdominal approach. That's why this is stated. In the abdominal approach, the surgeon can perform it by anyone conversant in surgery. That means not much of skill is required in abdominal approach, whereas for vaginal approach is slightly difficult than the abdominal and more skill is required. Time of operation can be done at any time, that is puerperal or interval. However, in vaginal approach, it is the interval period which is most suited. May be done in other times provided the uterus is smaller than 12 weeks. So during puerperium, this vaginal approach is not suitable. Contraindications, abdominal approach practically nil, or the uterus should be less than 12 weeks size. And if vaginal approach, contraindication is that if there is an associated TO mass and the uterus is more than 12 weeks, then vaginal approach should not be employed. Anesthesia in abdominal approach can be done under local anesthesia, and depending upon the anesthetist, it can be spinal anesthesia also. And in vaginal approach, general or spinal anesthesia is usually needed. Complication during surgery, it is easy to tackle if it's an abdominal approach, and it's difficult at times, and laparotomy may be necessary if some structure slips from your instruments. The duration of operation is less in abdominal approach, ever longer in vaginal. Complications are few. Wound infection, peritonitis is rare. In vaginal approach, also there are few, but sometimes a hemorrhage can occur, which goes into the broad ligament and hematoma forms. Injury to the rectum can occur rarely. So the complications slightly more in the vaginal approach. Then the late complications, incisional hernia, failure rate, which is less. And in vaginal approach, it is because we are going through the vagina. Dyspareunia can be there, and failure rate is more in vaginal approach. Hospital stay is more in abdominal approach, which is 5 to 6 days, and shorter in vaginal approach. And in abdominal approaches, the post-operative period is the stay is shorter than the laparotomy. So mini-lap sterilization is quite popular, which is now being done. What is mini-lap? It is an abdominal surgical approach to the fallopian tubes by means of a small incision, which is less than 5 centimeters in length, and preferably should be less than 2.5 centimeters. So it is suitable for interval cases and in patients undergoing MTP, and Pomeroy's method is the preferred method. So even though the uterus is not palpable in interval method, as in the puerperal cases, the operation can be done easily with little training. So pre-operative packing of the vagina or elevation of the uterus by uterine elevator. These are the various types of uterine elevator, which goes into the uterine cavity and elevates the uterus. So once the uterus, and that is the fundus of the uterus, comes near the anterior abdominal wall, it is easy to approach the fallopian tubes, and then can be easily identified also. So the uterine elevator, it helps to push the uterus out of the pelvis into the suprapubic region. So a small incision is made just above the pubic hairline. It can be the transverse or midline longitudinal. The preferred one is transverse incision. And precautions like emptying of the bladder are important, otherwise one is liable to injure the bladder, because in this we are going quite low suprapubically. And the skin incision is extended downwards, and various structures, that is the fat, the rectus sheath, and till the peritoneum we go, and then the peritoneum is carefully opened, and be careful that we don't injure either the bladder or the bowel. And then the tubes, once you reach the peritoneum is opened, the tubes are identified and they're hooked out of the incision, and then the entire length of the tube should be examined till we reach the fimbria. What happens is sometimes we confuse with the round ligament, so to avoid that confusion, always we should trace the whole of the fallopian tube till the fimbrial end, so that we are certain that we are dealing with the fallopian tube only. So here the isthmal portion of the tube is caught and the tube is cut. The various methods of sterilization will be coming to later. So this is the common one which is employed. The cut ends of the tube are ligated with a single round suture using a 1-0 chromic catgut, and hemostasis is confirmed, and the same procedure is repeated on the opposite side. So the incision in the anterior abdominal wall is closed in layers, and the rectus sheath and then the skin, after ensuring that the proper hemostasis has been achieved. So coming to the various methods of tubectomy which can be done. The most popular, as I said, is the Pomeroy's method. Here what we make is we catch the hold, the tube is nearer to the this thing coronal end, somewhere in the middle, and then it lifts up, and then the loop is formed, and then here we tie it over there, that fallopian tube. So about 2 to 3 centimeters of the loop is formed, and then this thing leaving little bit of fallopian tube over there, then this tube is cut. So this is the picture after a few months. These ends later on they retract. Here also we can see the loop has been formed, this thing is cut, and this is after a few months of sterilization. The ends have drifted apart. The modified Pomeroy's method is the one which is being done now. Here what we do is the loop is taken, the tube is lifted up, loop is made, and on one end the transfixation suture is put in the avascular area, otherwise there will be bleeding. So the avascular area of the mesosalpinx is seen, and one side of the tube is tied, then the other distal side of the loop tube is secured with a square knot over there. So this loop has formed, and then later on it is cut. The knot is cut. So then there is a Medliner method. This was one of the first methods which was employed. Here the loop is formed and it is crushed, and at that point the suture is tied over there, and this loop is not cut. This procedure has had the quite high failure rate. That's why this has been abandoned, and the Pomeroy's method has become popular. So another method is Irving procedure. In this, the tube is divided in the region of the ampullary isthmic junction, and the ends of the suture are kept long for traction and for use in the subsequent steps of the procedure. Using the blunt dissection, a tunnel is made at the back of the uterine myometrium, and the proximal tube is pulled and inserted into this a tunnel over there and sutured, and the distal tube is then buried within the substance of the broad ligament, and additional sutures may be necessary to close the defect within the mesosalpinx and adjacent broad ligament as a result of the previous dissection. So this will be the picture. Here the zinc tube has gone into the myometrium, and this is the distal portion of the tube, and the quite successful failure rate is very low in this case because they are so wide apart. But doing this procedure is quite difficult and time consuming. Then there is a Yoshida technique. In this, saline in epinephrine solution is injected into the subserosal area of the tube, causing the muscular tube to separate from the serosa. And this balloon serosa, this is the balloon serosa, it is incised and the muscular tube is withdrawn from there. A 5 cm section of the tube is then excised, and proximal end is tight, ligated, and the purse string suture is applied over there. The procedure may be extended so as to include the fimbriectomy and removal of the isthmus and ampulla with another suture placed in the around the mesosalpinx. So this is the end picture of the Yoshida's technique. In the Parkland procedure, it is almost there is little similarity with the Pomeroy's method, and this is also the failure rate is low. This is a partial salpingectomy procedure. In the Pomeroy's method, the window is created later. Here the window is created first. So the tubes are held, and we see for the avascular area, and with an instrument, with the scissors or a hemostat, we create an opening over there. That is, a window is created, and by opening the hemostat or scissors within the window, it can be stretched in parallel with the tubal lumen. A 2 cm segment of the mid portion of the tube is then ligated proximally and then distally with a separate xerochromic or plain catgut sutures. The segment between the suture ligament, this thing is then excised, and that is sent for the histopathological examination for confirmation of the tube. And here what happens is, because they are 2 centimeters of the tube has been excised and we are ligated over here, and then the window has been created. At this instant, at the time of surgery itself, the ends have drifted apart as come this thing, as against the Pomeroy's technique, where the ends were nearer at the time of surgery and later on they had this thing drifted apart. And the failure rate of this method is similar to that of the modified Pomeroy's method. This is another tubectomy which is almost similar to the Parkland method, though the name has not been given. In this we put 2 clamps. First we have, of course, identified the avascular area, and this is drawn up with a dissecting forceps. And where it is avascular area, the curved clamps are put like a V-shaped, and the tissue enclosed between the 2 clamps is then excised, and the tissue enclosed with the clamps is ligatured. That is, on this side 1 stitch is put, and other side the stitch is put. Then the tissue enclosed in the clamps is ligatured, and no effort is made to bury the ends of the fallopian tube. The end result is almost the same as that of the Parkland method. So here also they have drifted apart, and when we are seeing over here, so this is the picture over here, and the same picture comes in this method. So though this is operation simple, it gives excellent results, and subsequent adhesions have been shown to cause no trouble when this method is employed. Then there is Aldridge method, in which by blunt dissection a pocket is developed within the substance of the broad ligament. The traction sutures are placed within the muscular layer of the distal tube and are used to draw the infundibulum into the peritoneal pocket. After creating a pocket over here that has gone into the femoral and has gone into the peritoneum. Then traction sutures are placed within the muscular layer and they are used to draw the infundibulum into the peritoneal pocket, and this shows the end result. So we can see the fimbria over here, which is inside the peritoneum. The non-absorbable sutures are employed over here, and which anchor the infundibulum, that is the femoral end of the tube, to the new anatomic subperitoneal location. Our care must be taken to ensure that the entire fimbriated portion of the tube is firmly held beneath the peritoneum. So it is held beneath the peritoneum, so that whenever the ovulation occurs, the ovum cannot pass through this femoral end. Chronofimbriectomy is a suture is anchored in the mesosalpinx and placed around the tube in the distal ampulla. A second suture again may be placed adjacent to the first, and the infundibulum of the tube is excised. So this portion is excised and goes away, and this is the end result. The fimbriated portion is gone, only this medial portion of the entire tube is there. So the tube as it appears following the excision of the distal tube. So since the ovum cannot enter and this is blocked, the fertilization will not occur. Few words about the vaginal method. Though it has been obsolete now, it's generally done under local anesthesia, sometimes under general anesthesia. The minimal hospital stay is there and it is safe. Here what we are doing is putum speculum, catch hold of the posterior lip of the cervix, enter the posterior fornix, put an incision over the posterior fornix, then the vaginal wall and the peritoneum gets cut, and then you bring out the tube and do the various procedure methods which have been just now described. So this is still difficult to do as compared to the mini lab procedure, and in this case the disadvantage is that some develop hydrosalpinx and menstrual cramps, dysmenorrhea and dyspareunia may be there. Operative failure is slightly more than that of the abdominal approach, and of course skilled surgeon is required, and nowadays it is not being performed.